Hey everyone, it's Naomi Wolf of Daily Clout, and I'm so thrilled and honored to be joined by Dr. Andrew Bostom, who's dialing in from Providence, Rhode Island. Welcome, Dr. Bostom.
Thanks for having me on, Naomi.
Or I should say rural Rhode Island. Maybe
Rural Rhode Island, right.
maybe you're not right in Providence. But I'm so happy to be talking to Dr. Bostom today because, as many of you know, I've spoken to a number of distinguished scientists and physicians who have various views that are not the kind of views always reported in the New York Times, but there are various views about this kind of medical nightmare we find ourselves in and the policy nightmare we find ourselves in. And Dr. Bostom has been vocal on Twitter with very impressive kind of peer-reviewed documentation that brings a different light onto the subject and a different voice. So I really want to welcome you. Dr. Bostom is an epidemiologist and a patient-related researcher at Brown University, and he's here to share a number of subjects with us. So thank you for joining us.
Thank you.
So let's start with what led you to start posting some of these peer-reviewed links about, for instance, masks and coronavirus that are somewhat different from what some of the dominant narratives involve.
Right. Well, with regard to masking specifically, what was striking, I think it was striking to the public, it wasn't just me, was the dramatic sort of volte-face on the dramatic shift on the issue of masking, something that's becomes, Dr. Fauci, and he sort of gave this, I mean, even at the time, it sounded rather cynical and unusual excuse that there was a limited supply of masks. He didn't want the public going out and depriving frontline healthcare workers, et cetera, emergency service workers of masks. And that was rather strange, too, because then they started recommending, cloth masks. And obviously, there wasn't a shortage of cloth. So it didn't make much sense. And it actually got me interested in looking at what the scientific literature said, particularly because, as a clinical trialist, I mean, that's really what I've done, albeit, admittedly in a different area, in cardiovascular disease and chronic kidney disease. The principles are the same. So if you have something as complex as ultimately a vaccine or as simple as a mask, it's an intervention that, I started my career as a physical therapist, back in 1980. And then went on to medical school. But that whole 40-year plus period now, the paradigm has been evidence-based medicine. Right. And when it comes to interventions, again, as simple as a mask, as complex as a vaccine, the gold standard has been for those 40 years a randomized controlled trial.
Right.
And so when I went to the randomized controlled trial literature, again, coming from a different field, I was absolutely shocked at the consistency of negative evidence with regard to masking, particularly in the non-medical setting. It was just shocking to me. And published by the CDC, well, I would say that it is the CDC's House Journal, for example, Emerging Infectious Diseases. They did a very, very straightforward, what's called a meta-analysis, where they just pool studies, completed studies. This was an analysis of 10 randomized controlled trials. And one of the reasons they do this, Naomi, is because individual trials can sometimes be small, and even if they're negative, and by the way, all these trials were negative individually. However, there could have been a signal in there when they pool the data together, if there were small effects which didn't reach quote unquote statistical significance, but now that they aggregate the data, they put it all together, these smaller beneficial or potentially beneficial effects can emerge. Well, what was striking about this meta-analysis is that even the pooled data remained negative.
Wow.
And
I just jump in
Sure.
right there, kind of make sure everyone understands exactly what you're saying. When you say remained negative, you're saying it didn't show, even when they put together all these studies, all these different studies about masks, it did not prove that masks benefited people.
That's
just coronavirus. Is what you're saying?
Absolutely. In other words, the individual studies, which were, again, you could criticize them. Maybe they were too small. Maybe they missed small beneficial effects. When you aggregated the data, when you put it all together, they were still negative. And they were actually very interesting studies because they ran the gamut. There was actually a pilot study that was done of Hajj pilgrims, randomized by tent. There were a couple of studies that were done on campuses. Actually, it turned out to be the University of Michigan in two different waves, comparing dormitories that were masked and unmasked. And then there were seven.
There was no difference between the masked and unmasked dormitories
in any of these studies individually, although, again, you could say maybe there was trends that were missed. Then they looked at 7 household studies. And right. Here it was particularly interesting because, and relevant to COVID-19, which transmits primarily in the household. But what they looked at, this was influenza transmission. And they looked at whether, and randomized by household. They looked at whether just the infected person was masked, whether just the uninfected household members were masked, or whether all parties were masked. And in each one of those variations on that theme of household transmission, masks were ineffective. Then go forward beyond this meta-analysis, just this fall, 2 enormous studies, these individual studies, one of Hajj pilgrims, which was a mega study, a new, like the one that I mentioned that was in the pooled analysis was kind of like a pilot for this enormous investigation. That was just published in October. Over 6,000, again, randomized by tent. They were looking primarily at flu, but they cultured and they tested for all respiratory viruses. Not only was there no benefit to those that had been randomized to the tents that were masked, but there was actually a suggestion, it almost reached statistical significance, that those wearing masks had an increased risk of at least laboratory confirmed infections. It didn't reach statistical significance. And what was interesting, Naomi, is the way they, because they're disappointed, I guess. They had, they were hopeful. I mean, look, well, actually, why wouldn't anyone be hopeful that a simple intervention like a mask would actually reduce the risk of respiratory viral infection? And what they said is, gee, maybe there was poor compliance. And I was like, well, what do they mean exactly by poor compliance? Well, no, they spelled it out. They had expected these poor Hajj pilgrims to wear the masks literally 24 hours a day. And I said, well, wait a minute, maybe that's actually why you increased potentially rates of infection. I mean, because, and why you didn't get 100% compliance, certainly. Then 1 month after that, the most relevant study.
You don't literally mean 24 hours a day in their sleep. They weren't expecting them to be masked.
Yes, that's the way it was. It said 24 hours, so that's what I have to assume. I mean, they're sleeping in tents, and they were supposed to wear them. I mean, so no, of course, there was very poor compliance. It's absurd. Right. But then there was a study that came out and published in a very good journal. It's called PLOS, P-L-O-S. It's one of the original online journals, but highly respected. If you pay attention to these things, I usually don't anymore. It has what's called a high impact factor, so it's very impressive. And then a month after,
journal. It's a
peer reviewed journal. And then a month after that, the Annals of Internal Medicine, which is a preeminent internal medicine journal,
yes,
published the now well known, or at least in certain circles well known, Dan mask trial, which was specific to COVID-19.
The Danish study.
Yes, the Danish study.
Which found no difference between masked and unmasked.
Absolutely. Now, people have said, well, it was
about the Danish study, please.
Yeah, so it was done through a company in Denmark, company employees, and they ultimately randomized them. I think 4,900, and not a small study, Naomi. I mean, we'll go back, that meta-analysis that I was mentioning, that pooled 10 studies, was smaller, even when pooled, than either the Hajj pilgrim study that I just mentioned or this Dan mask study. So the Dan mask study, 4,900 persons completed this study. I think I lost you. So we back?
Yeah.
So 4,900 persons completed this study.
Start over. We're going to have to edit out that beat. Just start that sentence over. 4,900 persons.
So the Dan mask trial randomized 4,900 persons completed, and I think originally the randomization was about 6,000, and there was some loss to follow up. And so what they found was that there was no difference between the group randomized to masks versus no masks. Again, it's not a with masking. there's no such thing as a placebo mask. I mean, you can give a
Right.
placebo medication to someone that
Right.
looks exactly. You're either masked or unmasked. So it's randomized, but it's not blinded. Um, and that's the way they all have to be conducted. But there was no benefit in terms of reducing the rates of infections, specifically of SARS-CoV-2, of COVID-19. But they also ran a panel of other respiratory viruses, and none of those, even by random, reached statistical significance. There was no evidence, like there was sort of a slight signal in the Hajj pilgrims of an increased risk, but there was no benefit. And, so one of the criticisms of Denmark's study was that, mercifully for Denmark, this was a period before the fall huge spike that they experienced. But there was still a background infection rate, and it did not, was not beneficial. So, I have to say that when you look at mandating masking, forget about saying, well, it's not going to harm you and maybe it's beneficial when you're in crowds. The idea of mask mandates in the face of this very consistent body of recent evidence, let alone earlier evidence that was suggesting no benefit, actually dating back literally to the 1918 flu pandemic. There
Really?
was a very interesting mea culpa written by a public health official from Northern California named Kellogg, who was a microbiologist. And he wrote this lament in 1920 about how, despite their best intentions, despite their aims, and despite willful compliance, and he's talking about Northern California, which was hit hard by the 1918 flu pandemic, they saw no change in the epidemic curve. Now, that's purely observational. Obviously, there's no control group or anything, but it gives you a suggestion that when we're told on the basis of purely observational data, much of it so intractably flawed, so terribly flawed, that you must wear masks, and then you ignore the gold standard evidence, which is uniformly negative, something is amiss. It's just not right. It's just
Wow.
not right.
So thank you so much for that magisterial summary of the non-evidence. And for those who are not scientists, can you explain why a randomized controlled study is the gold standard, and also what is a randomized controlled study?
Oh, okay, so the reason that it's evolved, it's actually kind of interesting. There was sort of a landmark monograph, small analysis published by Campbell and Stanley in 1963-64, and it was called Experimental and Quasi-Experimental Design, so non-experimental design. And they walk you through in a very concrete fashion. I guess it was designed for graduate students at the time. And most of the literature was about agricultural experiments. But they just walk you through all the biases in observational, uncontrolled studies that can't be eliminated.
What's an observational study?
So you have a group, you look at them at point A, and then you intervene on them in some way. Maybe you give a certain fertilizer in the case of agricultural experiments, right. and you look at the end point and you say, aha. And what they point out is that, well, maybe there was good weather during that period, right. More rainfall, right. All kinds of variables that are not controlled for by that sort of uncontrolled design. Gotcha. And those principles apply to medical interventions as well, the natural history of the disease, et cetera.
Understood, or who those people happen to be, or other factors that might be affecting them. So,
or the observer, because there's the observees and the observer. The observer wanted this fertilizer or wanted this medical device to work, and right. therefore is biased in their interpretation, knowing, et cetera.
A randomized controlled study corrects for those flaws by duplicating the group and duplicating what you're looking at and creating exactly the same circumstances except for one variable, like masked, unmasked, correct?
Exactly. That's exactly what they're doing. And so the time period is the same. Right. The methods of in this case for COVID or other respiratory viruses, the methods of determining them, whether it's a clinical diagnosis or a laboratory diagnosis, are exactly the same. Right. And the idea that you would be in the group that wore the mask or the group that didn't wear the mask is literally like a coin toss.
Gotcha. Gotcha. Okay, so that corrects for all kinds of flaws. I mean, that
Naomi, the other thing it corrects for is it, especially if it's big enough, like these big trials that I mentioned, the last two,
yes,
the idea that there'd be sicker or more susceptible people in one group versus the other is eliminated through the random process if it's big enough.
understood.
And that's why they've become the goal. Now they have their flaws too, because that's, as Yogi Berra said, in theory there's no difference between theory and practice, but in practice there is. You can still screw things up with a randomized controlled trial, but that is the idea, and none of that really pertains to an observational study. At best, you can tinker statistically after the process is over and try to adjust for those imbalances, but it's not the same.
Gotcha. So this is pretty mind blowing. A distinguished epidemiologist connected to an Ivy League university is noting conclusively that there is no evidence from many, many gold standard level trials that masks make a difference. And yet there are mask mandates, affecting children. I mean, my stepson,
Oh,
public
that
school,
that's worse.
Massachusetts. Please speak to me about the fact that in spite of no evidence that it helps, and I actually interviewed an OSHA PPE specialist who said
Mhm.
that there are harms to wearing masks all day.
Potentially, yes.
So speak to the harms, but also speak to what do you feel as an epidemiologist that children and college students are being forced to wear masks all day long, people in retail, people working with the public, when there is no evidence that it helps them? Please tell me your thoughts about
It's, I mean, you have to use pointed words. It's oppressive. It's inappropriate. I mean, it's medieval. I mean, if you're going to use medieval as a pejorative, I mean, it's as a negative. It's not appropriate to where we're supposed to be when it comes to interventions. And again, masking. Oh, come on! It's not a vaccine. It's not something that people are inherently fearful of. A drug, etc. It's a simple thing, so but it's still imposed on people, again, without their informed consent. I
right.
mean, I saw a priest actually testifying about the mandate still existing in Ohio, gave a wonderful analogy. He said the Department of Health in Ohio, and you could apply this to all departments of health, are treating Ohio citizens as if they're hospitalized patients without informed consent.
This is a version of exactly what Megan Marshall, this OSHA expert, said. She said that um, everyone is being treated as if they're immunocompromised, as opposed to just immunocompromised people being treated as if they're immunocompromised.
Well,
So,
and in terms of children, first of all, Naomi, the closest we got to that age bracket in terms of good randomized controlled trials were the two University of Michigan studies, and those are 18, 19-year-old freshmen, primarily in this study, as I recall the methods. Um, there's not even a trial that's been attempted in kids, and this is being imposed on them. That's
wow,
really
that is
awful,
that is
and
Nuremberg
and
law
that's
level.
awful, and you're talking about um, kids that depend so much on interaction with teachers and and their peers, that to not be able to see facial expressions, to have muffled voices sometimes where they can't hear each other, and then I mean, parents have literally brought home masks at the end. I'm sure you've seen these too, whether they're cloth or paper. And you can imagine a kid with a cold, what the mask looks like at the end of the day, if there haven't been multiple attempts to change it. It's awful. Even nurses. I saw one study of nurses who were wearing N95s in the respiratory care unit, in the respiratory ICU, and they did it. And that's, I think there's nothing unreasonable about them doing that specifically for patients infected with viruses. Other types of infections, it's not very clear how helpful masks really are, but be that as it may, they complained. They had a number of complaints after an 8-hour shift. And while their blood oxygen levels did not desaturate, they did show a statistically significant increase in their blood carbon dioxide, which didn't
Really?
reach what it's called hypercapnia, if it's sort of clinically alarming. It didn't reach that level, but it rose, and it may have been associated with some of the symptoms that they were feeling. But
What? So
again, that's a very different that's a very different environment where, you know, you could say, well, the benefits might potentially outweigh the risk. There's no such equation for kids in a
Right.
classroom,
Absolutely.
particularly the way this disease affects children. And what we now know about transmission in the school, including to teachers.
Which is
In
what, Dr. Bostom, what do we know about children?
Well, so if we want to keep it local, North Carolina just this past fall, and the paper was published already in Pediatrics, which is a preeminent pediatric medical journal. There was a number of school districts that had in-person, you know, teaching, and if I'm recalling numbers correctly, I believe there were 90,000 teachers and students in this again observational study, and they did contact tracing. And they found that 96% of the infections could be traced to the outside community. Only 4% could be traced back to the schools. And of those infections in the schools, they did not find a single case of child to teacher transmission.
Wow.
And that's very important because the kids are at extremely low risk, but you could have a teacher, an older teacher, a teacher with comorbidities who might be more susceptible to serious, you know, outcomes from COVID. But there was literally no transmission that they could trace in a number, you know, that's a fairly sizable population in 90,000.
Yes.
And so that's in our backyard. You know, here in Rhode Island, we have one talk show host who has been pretty dogged about this, Matt Allen, and he has tried to get that information from our Department of Health, and you know they're very cryptic about these things. They're very reluctant, but he got some information that the numbers sounded very similar to North Carolina, that they could only track about 5% of the cases. In this case, I think there was 2,500 cases in the schools in Rhode Island, to the school setting itself.
Wow.
So it's
we're doing with kids is an experiment based on no science. Masking children is an experiment. There are no studies showing that it's safe. There might be harms we're not aware of. This OSHA specialist, Megan Marshall, said children will need speech therapy because they learn to read and speak from looking at people's lower faces.
Naomi, my wife is a dermatologist, and she's seeing she sees some kids, but very few, more adolescents. And she's seeing a lot of people that are developing all kinds of, you know, rashes from mask use. Kids are developing some rashes, some fungal infections and things like that. You know, again, they're not life-threatening or anything like that, but you know, why? I mean, they shouldn't be wearing them at all.
First, do no harm.
Exactly.
Right? Imposing harms on children when they are not at risk, and there is no science saying that it's safe to mask them.
But by the way, moving to Scandinavia. A couple of really interesting studies. One, obviously, from Sweden during their big spike, which was the first wave, the spring spike. They did not record one pediatric death in Sweden during the big spike. Right. Kids up to 16 years old had face-to-face instruction. They looked at infection and hospitalization rates in teachers. If anything, teachers were below the mean for other occupations in Sweden. Norway was more strict, but then looked at when things reopened over the summer into the fall. And there was a study that was published early this year from Norway, again, reproducing this idea that there's very little transmission in school. And Norway, like a lot of Scandinavia, kids are in school without masks.
Right. Wow.
So even without masks in school, there was no evidence, or I shouldn't say even, but without masks in school, there was really no evidence of significant transmission.
Extraordinary. And yet our children here in the United States are either home or being put into, as you say, a kind of medieval, kind of experimental imposition on them, which I think has terrible, terrible harms developmentally. And it keeps them from doing so many things that your brain is supposed to learn to do when you're a child. You know, you talked about
and the fear, Naomi. It's like a talisman. You know, my wife wears a Hamza with an eye in it. You know, and that's great. You know, but it's one thing for her to wear it. It's not appropriate for her to mandate that all her patients wear it. You know, to keep away dermatologic diseases. I mean, it's just, you know.
let me ask you about um, the design of studies. I'm not a scientist, but I encourage everyone to learn to read peer-reviewed studies. They're not impossible. If you're not a scientist to figure out, you get used to it. And what's really struck me is how misreported a number of studies have been and how bad the science is around COVID. Let me give you one example.
Sure.
A, a much cited study about schools suggesting that there was danger to teachers took a big group of students and a big group of teachers and said, look, there are this many infections. And that was how it was reported, that, kids are infecting teachers. But when you actually looked at the study, it showed that there were household infections
Exactly.
that affected teachers and household infections that affected students. But it was just misreported that the transmission happened in schools.
Well,
and are you seeing bad science or misreported science around the issue, COVID related issues?
I'm seeing both, actually. Yeah, I mean, Naomi, we've had, I've never seen this before in such a short period of time, certainly. Two major, highly respected journals get hoodwinked, essentially, and accept data from essentially a sham operation. The Lancet and the New England Journal accepted papers from this ostensible medical group that was collecting data, internationally, and it turns out that they were fraudulent. They had to retract the papers.
Wow.
And of course, one was extremely negative about hydroxychloroquine.
Right.
And then I actually even forgot what the other one was about, but it was the same group. In other words, they were fraudsters, and they hoodwinked these two journals. But because the journals, for whatever their reasons are, Naomi, had a certain outlook on where COVID policy should go, they were very happy, particularly the one about hydroxychloroquine, to accept it, and then had to retract them. I've never seen that before, certainly in such a condensed time period.
Well, this is incredible. So we could talk so much, and I hope you'll let me circle back to you again. But let me just ask you as a final question for this interview, which has been completely eye-opening, and I'm going to immediately, send it to Governor Baker so that my stepson can get out of his mask.
One quick thing for Governor Baker, can I tell you? Yeah, there's so everyone's now the latest, and we call it what we call it, Naomi. I'll be honest about it. I call it panic pornography because that's what I think it's become. It's horrible. It's just made to, if there's a Hippocratic oath equivalent in epidemiology, it's above all cause no panic. Because these phenomena are frightening enough in and of themselves. You don't need to pile on.
Right.
But the variant issue in Massachusetts, I just saw there's a site that tracks how a variant is predominating or beginning to predominate. And Massachusetts now is over 30% of the feared UK variant, the B.1.1.7 UK variant. And yet, if you look at all the nice indices, the infection rates, the hospitalization rates, the mortality rates, they're all continuing to steadily decline over the period where this strain became predominant. And that's very good news.
Right.
And people should, accept good news too.
Right. I mean, I've done close reporting on how data are presented around COVID, and there's absolutely an unjustifiable, incredibly unethical mispresentation of data to, if things are going well, you focus on what can be scary, the variant, right? And, if you can lump all deaths and present them as if they all happened today when they happened over the last 12 months.
Oh my God. Naomi, as an epidemiologist, that I never heard of so-called, quote, date of report recording. You can't make a curve or a survival curve on that basis. You have an event, it happened on a specific date, and that's when you plot it. The idea that, because these reports filter in to the Department of Health over a period that sometimes dates back weeks to months when they finally adjudicate deaths, that you could lump them all in on the date they're reported.
Right. You create spikes.
It's crazy.
I've warned people about this, right? Isn't that what you're saying?
Absolutely.
Aggregated.
Naomi, I was a death adjudicator now it's a different outcome, for sudden cardiac death. And sometimes, we were reviewing from the Women's Health Initiative, we were reviewing data that was, 5 years old or more. I mean, okay, so if I'm adjudicating something in 2015 and the person died in 2010, I can't say they died the date I adjudicated. It's just ridiculous.
Right? And that's what's
ridiculous.
COVID death report.
Now, it's more condensed with an epidemic. You're talking about weeks or days as opposed to years, but the principle is the same.
Thank you. The point is that we're seeing spikes that are not necessarily actually spikes. They're when data are processed.
It's invalid, Naomi. It's a meaning. You don't die on multiple days. It's a meaningless. It's a meaning. I looked at these curves. I said, why are they doing this? It has no mathematical, no logical meaning, and yet they're getting away with it. Now, I did see a caveat that if you literally have no other date, you can use that. But that's a contingency as opposed to having nothing. Not as most of the time these days are very clear cut. And what's even more misleading is if you go to the data dashboards for some of my state of Rhode Island, they have all the date of death and the date of hospitalization by actual date reporting. And they do include it, but you have to go to a back page and it's graphed out for you. If you look at the face sheet, they go, quote, new deaths. And I'm like,
so evil. That's
terrible. It's terrible.
So misleading.
And that's all the reporters report, by the way.
And that's what the reporters report.
Now, what it does, it cuts both ways, I will say, Naomi. As the death curve, morbidly, unfortunately, is going up, the date of report can miss some of that.
Right.
But the big problem is that as things are getting better, you're piling on deaths that happened weeks to months ago, and it looks like we're still in the middle of the spike.
This is
terrible.
Such a point to make, and I want to thank you for being, making me feel a little bit less of an obsessed nerd about this, because for a year, because I run a data dashboard, at Daily Cloud, I know that you can tell any story by how you present the data. And I've been warning people the way these COVID dashboards are presenting the data is misleading. It is fake news. And the way
look for terms like new, in particular, new. No, just say they should have a term past day, past 24 hours, period. Right. That's it. That's it. And understand that can underestimate, because there are going to be some adjudications or late reporting. So just say that. We could add to this, but here's what happened in the past 24 hours as far as we know right now.
Completely misleading. Well, look, thank you so much you're making me feel like saner by the minute. A lone voice saying no, the dashboards are misleading. But you're confirming that. So the last question I want to ask you, and you've been so generous with your time, and don't worry, we will come back to you, as much as you let us, because we talk about, there are many things we haven't addressed. As an epidemiologist, looking at the big picture, I've been interviewing people like the signers of the Great Barrington Declaration, and
wonderful folks, really doing wonderful stuff. I very courageous, and out there, and listen, as I told you, I mean, we all have different political viewpoints, and it's the same thing with those guys. They actually include an interesting group. They have a guy that I would consider, I won't name him, but a guy that I would consider, sort of a centrist. And then they have, two, near socialists, but they're all together on this.
Well, so now you're out in public being brave also. But, increasingly, I think we have more and more company as people realize, that this medical narrative is kind of falling apart. As an epidemiologist, do you see harms from lockdowns the way they do? Or is public health being hurt? And what are
Naomi, I just read a UN report, and again, as someone of my political persuasion, I'm not a huge fan of the UN at all, but the UNICEF still does some good work, and their estimate is that, and these are neonates less than 5, neonates to less than 5 years old, almost 230,000 preventable deaths driven in Asia. This is just Asia, driven primarily by the sprawling countries of India and Pakistan, because of the lockdowns and because of inattention to, prenatal and perinatal care, immunization programs, et cetera, treating early childhood diseases, and that's it's catastrophic. It's catastrophic. And then when you get to developed or developed parts of those countries and the developed world in general, There's a lot of phenomena that we're I think we're going to see. We get hints of them in missed screenings. People literally, I have cardiologist colleagues telling me anecdotally that, there are people that infarcted at home, that had heart attacks at home, that had strokes at home because of the terror of going into the hospital and acquiring, coronavirus in the hospital. And it has been spreading in hospitals. I mean, it's not a totally irrational fear, but that versus dying from a heart attack, when you could get treated and treated in a way where you didn't get COVID. It's just these things are gonna add up, and then all the psychosocial stresses, the stress of being unemployed, and lots of breakups of marriages, and I think it's going to have a colossal effect, and we darn well better not do it again. And the old epidemiology said, don't do this.
Right.
Weather it out, but don't do this.
Right.
Because it's too destructive.
Such an important point to end on when you were saying the job of an epidemiologist is to not panic people. I was very struck by other public health officials at very high levels in Canada, for instance, saying old epidemiology is carry on as normally as possible, support.
Naomi, the most influential paper that I read, again, as someone who's coming from a different branch of epidemiology in cardiovascular disease and chronic kidney disease, was by Donald Henderson, who used to head died in 2016, I think, but was the head of the Hopkins School of Epidemiology. Was literally the man who went out into the field and spearheaded the smallpox eradication program. He wrote almost presciently about in, I think it was about 2006 or so, about projections for if there had been a pandemic flu recurrence, about why you should not lock societies down. That it's so dangerous, and that the costs will be greater than anything you expect. And he said that mask mandates and things like that were probably pointless.
Right.
He was less harsh about that, but he said they certainly hadn't worked in the past, and why would they work in the future?
Wow, fantastically important. So to conclude, it sounds like a lockdown is, in your view, a catastrophic and perhaps one of the most catastrophic public health decisions.
Absolutely. I think, especially with something like COVID as it evolved. I mean, we got a hint of this, but it, you can err on the side, maybe a short period of lockdown, you can understand that. But when we saw how stratified it was, how focused it was, particularly on the infirm elderly,
right,
and that very different than other respiratory viruses, particularly influenza, which is much more dangerous to kids. Even seasonal flu, Naomi, is much more dangerous to kids. Yes, absolutely. And and anyone can look this up by CDC data. So if you look at the recent bad pandemic flu that we had with H1N1, which was actually pretty mild for adults, it wasn't so mild for kids.
Wow.
There were over 1,200 deaths in the pediatric age group, and depending on which metric you refer to from the CDC, there's maybe about 230, 240 up to the age of 17 now from COVID.
Right. And wow. Flu is much more serious.
And even I looked at even recent seasonal flu years where you can get numbers of 800, 900 compared to this 230 that we've had or so for the past year.
Wow. So really, we're harming a whole generation of children and young adults for no epidemiological reason at all.
Really, none.
It's been completely eye-opening. We could talk for hours and hours. We'll come back to you whenever you let us.
Sure.
Dr. Bostom, I want to thank you so much for your expertise, your authority, your courage in speaking out, and you're being a real, doctor. You're being a real physician and a real researcher in trying to tell the truth to people about this public health crisis. Thank you so much.
Oh, thank you. Thanks for having me on, Naomi. Appreciate it.
Look,
okay, bye.
Talk to you soon. Bye-bye.
Bye.